Thank you for this opportunity to present my research on cost of postoperative ALIAs following colorectal surgery from an Australian institution. My name is Luke Traeger and I'm a General Surgical Registrar and PhD student at Royal Adelaide Hospital in South Australia. I would like to thank my co-authors for their assistance with this paper, as well as my supervisors James Moore and Tarek Small. Postoperative ALIAs is a common complications for patients undergoing elective colorectal surgery, occurring in up to 1/3 of patients. This results in significant morbidity and mortality for these patients. It has been shown in the literature to double the length of stay, as well as double the cost of admission. In the current literature, there's limited data of diagnosing postoperative ALIAs not using a validated composite measure instead of an ICD-9 code. As well, there is no current literature looking at Australian data of postoperative ALIAs. To fill this gap in the literature, we performed a single-centred retrospective study at the Royal Adelaide Hospital between 2018 and 2021. We included major elective colorectal surgery, and we defined postoperative ALIAs by not achieving GI2 by day 4, which is a validated composite measure of time to tolerance of oral diet and time to first stool. We collected data on demographics, operative details, and postoperative outcomes, and this study had ethics approval. Our primary outcome was the total cost in Australian dollars of inpatient stay per patient. We then performed a subgroup analysis looking at departmental costs such as staffing, theatre, critical care, imaging and pathology services. We then analysed the data using a univariate analysis. So here you can see our selection flowchart looking at 151 patients who have developed postoperative ALIAs out of 432. We excluded minor cases such as hemorrhoidectomies, as well as excluded robotic cases because these are performed at a different site, as well as pelvic exenterations due to increased morbidity and mortality in these patients that would skew the data set. So when we investigated the demographics, male patients who were previous smokers or active smokers, patients with previous abdominal surgery, and cases that were converted from laparoscopic to open were more likely to develop postoperative ALIAs. The other variables were not statistically significant. So when assessing the complications between the two groups, both including and excluding postoperative ALIAs, we found that the grade of complications were higher in the postoperative ALIAs group. When looking at the 30-day outcomes, a greater proportion of postoperative ALIAs patients required TPN, had an increase in length of stay by 4 days, and had complications such as UTIs, pneumonia, cardiac complications, and DVTs or VTEs. So when we compared the costs between the two groups, patients with postoperative ALIAs had an increase in cost by $9,000, which equated to a 34% increase in total costs. When looking at the breakdown of other departmental costs, every department had an increase in total costs by approximately 1 to 450%. This study confirms that in Australia, as well as reported internationally, the financial burden of postoperative ALIAs is significant. Our postoperative ALIAs rate of 35% is higher than previously reported, likely due to the differences in postoperative ALIAs definitions being used. Other studies also include minor surgical procedures, which it may have also led to underreporting of postoperative ALIAs. The 34.2% increase in total cost of admission in our study is lower than previous literature reported. And this increase may be due to differences in postoperative ALIAs rates, as well as other studies not using a validated score such as GI2, which may have led to an overestimation of costs. Overall, this study does echo other studies by demonstrating that the increased length of stay by postoperative ALIAs, as well as complications, leads to a significant increase in overall cost. So our study did have some limitations. It was retrospective in design. However, we were allowed to check some of the data against a prospective unit database that looks at complications. This study was also a single-centred analysis, which reduces its overall generalizability. Our initial plan to perform a propensity-matched analysis was unable to be performed due to a range of demographic, operative and post-operative data that was collected. This was also thought to be of little clinical value, as patients often do not develop postoperative ileus in isolation from other complications. Thus, a univariate analysis was able to give us a representation of the true clinical cost to a patient who develops postoperative ileus. To be able to map the full economic impact of postoperative ileus in Australia, future studies with multiple sites collecting prospective data is required. So overall, postoperative ileus increases length of stay and complications. Approximately 1/3 of our patients developed postoperative ileus, which increased the total cost by 1/3. Strategies to reduce postoperative ileus would significantly reduce complications as well as have economic benefits. Thank you very much for your time.